Hi, my name's Dane Newville. I'm one of the pharmacists here at MD Custom Rx Pharmacy. Today we're going to do another video on methylene blue. We're going to go over some of the frequently asked questions off the YouTube comments. We're also going to dive into G6PD deficiency, what that is, what that means, and how it pertains to methylene blue. We're going to go over some dosing and frequency, again, touch on that. Maybe some advice that we didn't give in other videos regarding dosing and frequency, and then we are going to have the specific answer to the nitric oxide methylene blue interaction, what's going on there, because I think in that video, one clear winner, we didn't actually give that clear winner. So today you will hear the clear winner at the end of the video. All right, thank you. So G6PD, that is glucose 6 phosphate dehydrogenase, and it's a gene, but if it's a deficiency, it's kind of a gene mutation. So for sure, we're going to say G6PD. So G6PD deficiency leaves that patient more susceptible to hemolytic anemia. So a quicker breakdown of red blood cells, leading to an overall lack of enough red blood cells causing anemia. So G6PD is an inherited condition. It's on the X chromosome. So if you're female, you're less likely to have this G6PD deficiency than men because you get 2 X chromosomes. Or African descent people than other cultures. So 1 out of 10 African Americans have this G6PD deficiency. It also affects people of Asian descent, Middle Eastern descent, and Mediterranean descent the most. Okay, so what is the G6PD deficiency? Well, your red blood cells don't have a mitochondria, and they're going to be more susceptible to oxidative stressors that are going to cause them to break down. So your body has developed a certain pathway in order to make a reduction agent, NADPH we'll call it, and that actually helps reduce oxidated molecules so they don't destroy the red blood cells. So they're going to reduce any sort of oxidation that's coming around. ROSs, I've talked about in other videos, reactive oxygen species. Your mitochondria, when it's dysfunctioning, creates a lot of ROSs and actually can be hurtful, but also the mitochondria produces a lot of reducing agents. So red blood cells not having a mitochondria, they use NADPH to do reducing stuff so they can defend against early breakdown of the red blood cell. Fun side note, your A1C when you test your blood sugars, it's a reflection of your prior 2 to 3 months blood sugar level. It's because your red blood cells have about a life cycle of around 3 to 4 months, and that's what we want to keep. People with the G6PD deficiency are more likely to have a breakdown quicker, hemolysis, right? And so the cycle is going to break down quicker than the 3 to 4 months. So methylene blue is known to treat methemoglobinemia, but it can also cause methemoglobinemia. So methemoglobinemia is when your body has more methemoglobin and not converting it to hemoglobin. And in essence, you're not able to get oxygen to those certain cells from the red blood cells. So people with the G6PD deficiency are more likely to have methylene blue cause methemoglobinemia. And this is because, going back to that NADPH, that reducing agent for the red blood cells, people with the G6PD deficiency only have so many of the NADPH available. Well, when you take methylene blue, that NADPH is actually getting used to reduce methylene blue to leukomethylene blue as well. So if you're taking only so much of a reduction agent for the red blood cells and now you're introducing methylene blue, it's trying to reduce that and trying to help the red blood cells. It's just kind of overwhelming that reduction system. So it can push you into methemoglobinemia, again, where essentially you can't get oxygen to certain tissues. Now, I think it's the hermetic effect of methylene blue at very high doses for people without that G6PD deficiency can also cause methemoglobinemia along the same lines, where you have so much methylene blue in your system that how much reduction agent you have available is kind of getting used up and it can't turn it all into leukomethylene blue, gets overwhelmed, causing methemoglobinemia. It's just that people with the G6PD deficiency are more likely to have that reduction agent NADPH be overwhelmed or not have enough of it. So much lower doses of methylene blue can cause that methemoglobinemia. Interestingly enough, again, methylene blue can help treat methemoglobinemia by reducing methemoglobin to hemoglobin, but you do need that NADPH available to help with that process. So in summary of the G6PD deficiencies, it is X-linked chromosome inherited, so females far less likely to have it than men. It is something where your red blood cells need a reduction agent to fight off oxidative stressors. You only have so much with the G6PD deficiency. When you add methylene blue, now it's trying to reduce the methylene blue as well, gets overwhelmed, ends up causing a breakdown of the red blood cells and possibly anemia. So we highly suggest being tested for that G6PD deficiency prior to taking methylene blue. We don't want you to end up, anemic. We don't want you to end up with methemoglobinemia or methemoglobinemia. Someone's going to comment tomato, tomato on this one. But that's the summary here. So highly suggest get a test for G6PD deficiency. Your provider should be able to do this for you if if your provider's not capable. I'm sure there's someone in your area, a provider that has the test available. So highly suggest doing that prior to starting any methylene blue. All right, next up, we're going to talk about methylene blue dosing and frequency. So I touched on methylene blue dosing and frequency in other videos, but we're going to readdress it here. Adding in also like its bioavailability. So methylene blue, from what I've found, is bioavailable upon oral administration at around 53 to 97%. That means if you take like 100 milligrams orally, 53 milligrams to about 97 milligrams are going to be bioavailable, like active in the system. And then it peaks at 30 minutes to about 60 minutes. So you're kind of getting the max effects 30 to 60 minutes into it. And then the other piece that is interesting, and we'll talk on, this helps circle back to what we think best practice frequency of use would be, but its half-life is about 4 to 6 hours. So what does that mean? Okay, well, we're going to jump into it here. Circling back, most of the strength for oral methylene blue that literature suggests to be safe, relatively safe, is 0.5 milligrams of your body weight up to 4 milligram per kilogram of your body weight, with the bell curve, the average being about 1 to 2 milligram per kilogram, okay, of body weight. So that's how much they deem relatively safe having in your system. So now we're going to pair that to half-life so we can figure out if there's like maybe a best practice frequency here. So is it safe to take every day? The answer depends. We believe yes, but you may want to take a day off during the week. Here's our example. With a half-life being around 4 to 6 hours, say you take 100 milligrams at noon, orally 100 milligrams at noon. So at 6 p.m., with a half-life every 6 hours, 6 hours later, 6 p.m., you have 50 milligrams in your system. Midnight, you're going to have 25 milligrams in your system. 6 a.m., you're going to have 12.5 milligrams in your system. Finally, noon the next day, when you take your next dose, you're going to have roughly 6.25 milligrams left in your system. Now, again, this is using like the longest half-life, so the slowest metabolism value, okay? But regardless, being conservative, I think, is the best approach here. And so you potentially could have 6.25 milligrams left in your system when you'd be taking that next 100 milligram dose. If, in our opinion, like best practice to make sure that residually you don't add up where you end up outside of that 4 milligram per kilogram strength, which is deemed still safe, right? We want to make sure you don't slowly creep up over time. Taking one day off during the week might be the best practice to do that. By taking that one day off during the week, you're going to give yourself essentially 4 half-lives of no methylene blue in your system to break down any sort of residual that you had in your system. Okay, this is going to be a good way to ensure that we don't creep up over time too high where we get outside of that what is deemed safe 0.5 milligram per kilogram body weight up to 4 milligram per kilogram body weight dosing of methylene blue. Okay, all right. Lastly, I wanted to touch on, we did a video, it was methylene blue versus nitric oxide, one clear winner. I apologize, I think in the editing that the answer was never there, so I apologize. Hopefully you got stuff out of the video, but I'm here to just clear the air with that, give you specifics on what's going on. Is methylene blue inhibiting? Is it not? Okay. Well, the one clear winner is you. I know it sounds cheesy, but it's you, and here's why, okay? Methylene Blue does inhibit nitric oxide.
What?
Methylene Blue does inhibit nitric oxide, but there are three different forms. There are the inducible nitric oxide pathway, the neuronal nitric oxide pathway, and the endothelial nitric oxide pathway. The neuronal and the endothelial nitric oxide pathways aren't the ones that really cause havoc. It's the inducible nitric oxide pathway that does. That's the one that causes runaway drops in blood pressure, can be fatal, vasoplasia. After cardiac surgery, it can cause complications. People get it from sepsis and burns. It's when inducible nitric oxide runs rampant and just drops your blood pressure. So methylene blue has a very high affinity for inhibiting inducible nitric oxide pathways. That's why it can be used to treat vasoplasia, and that's why it's used in certain hospital surgical scenarios to help the patient recover that blood pressure. It also has a mild affinity, so very little liking to inhibiting the endothelial and the neuronal, almost arbitrary. Or I should say it's arbitrary, and here's why. So has a high affinity, really likes to inhibit inducible nitric oxide. Low affinity just barely inhibits endothelial and neuronal. But it's a wash on the endothelial and neuronal pathways because the mitochondria that the methylene blue is helping make more efficient, one of the complexes in the mitochondria can create essentially a nitrite reductase enzyme, which creates more nitric oxide. So that little bit of inhibition on the endothelial and the neuronal is washed out because those mitochondria are actually working better and creating more nitric oxide. So the net result of all this inhibition, selective inhibition here, more there, the net result is that methylene blue just inhibits inducible nitric oxide. This is why it can treat priapism. This is why it can treat vasoplasia. But this is also why your blood pressure doesn't run away from you, okay? And that's why it can treat runaway low blood pressure, but doesn't cause severe spikes in high blood pressure, all right? So hopefully that was a clear answer for you. It's not black and white, but hopefully I was very specific on what pathways it's blocking, to what degree, and what the net outcome is for you. As always, leave in the comments